She pursued her MBBS, MD, General Medicine, Gandhi Medical College, 1994 and 2000 respectively. She then completed DM Endocrinology in Usmania Medical College, Usmania General Hospital. She has been teaching this since 2000. Since 2000, she has been teaching as a tutor cardiology, Gandhi Medical College, then tutor endocrinology in Usmania Medical College, General Hospital, Assistant Professor of Endocrinology, Usmania, and Associate Professor of Endocrinology from till now. She will be talking about Turner syndrome.
Good morning. She is a very good teacher and good orator, and we are going to enjoy the real topic of our experience of Turner syndrome. So we had a good experience in our teaching institutions, especially Gandhi and Usmania. We had publications also, national publications and international publications regarding growth hormone therapies on Turner syndrome. So we have a practical experiences and we have a real patient data is there.
Which I am going to discuss is the growth hormone therapy in Turner's, though it's not a very common disorder, but it's a like very important disorder which can be managed with appropriate treatment and like early diagnosis. To begin with a case scenario which we have seen in our practice. So she was a 13 and a half year old girl, was brought by her mother for the evaluation of the short stature and the delayed puberty, and she was born to non-consanguineous parents, and it was a full-term normal delivery. Birth weight was 3.5 kgs and milestones were normal. Scholastic performance was good, and no visual disturbances, no CNS symptomatology, and no history suggestive of any chronic systemic illness. This is the background history. On examination, she was very short, like with the height being 130 centimeters, less than 3rd centile, and the weight 32 kg, in between 3rd to 10th centile, and no goiter, and her height age was 8 years, 9 months, and weight age was 9 years, 9 months. Height SDS was minus 4.16 SDS, that is severe short stature, and mid-parental height was 154 and target height was 146 to 162 centimeters. And she had a short neck and cubitus valgus, which are the like Turner stigmata. So, and she doesn't have any short 4th and 5th metacarpal or metatarsal. Generally, we expect it to be. No other skeletal deformities, and SMR was prepubertal, and otherwise vitals were very stable, and blood pressure was normal. That is very important thing to be examined in a like Turner's patient, because they can have a coarctation of aorta with a high blood pressure. So, and the systemic examination revealed normal. And routine biochemistry was normal, bone age was 10 years. Generally, bone age will be appropriate in most of the Turners, but sometimes it can be delayed. Thyroid was normal, antibodies were negative, and FSH was 199, which is very much elevated, suggestive of a ovarian insufficiency. And karyotyping was a classical of Turner's, 45XO. And ultrasonography suggestive of infantile uterus and streak ovaries. No other anomalies, because they can be associated with any other renal or other anomalies. And 2D echo showed a bicuspid aortic valve and trivial AS and no coarctation. So diagnosis with Turner's. So this is the case typically we see in our practice. So the concern is, the mother was concerned regarding the short stature. So can we do anything for the stature? So these are all the Turner's is one of the most common chromosomal disorder, affecting approximately 1 in every 2,500 live born females. So it is the result of absence or structural abnormality of one copy of the X chromosome. The diagnosis of Turner syndrome requires presence of characteristic features along with the demonstration of complete or partial absence of second sex chromosome with or without cell line mosaicism. And looking at the stature, there will be Turner syndrome, like short stature or growth failure is a universal phenomenon in almost all patients with Turner's. Almost they will be 20 centimeters shorter than the their mid-parental height. So these are all the phenotypic features of Turner syndrome, which I am not going to discuss in detail, because I just want to tell, like short stature is a universal phenomenon in Turner syndrome. And these are all the other various abnormalities, and again psychosocial problems like learning disabilities and all. So now our focus is on short stature in Turners. How can we address that problem? So what is the genetic basis for the short stature in Turner syndrome? So the growth failure is due to the haploinsufficiency of SHOX, that is the short stature homeobox gene located on the short arm of X chromosome. So you can see in the picture. So the SHOX gene resides in the telomeric pseudo-autosomal region 1 region on the short arm of both sex chromosomes and normally escapes the X inactivation. So this is because of the SHOX haploinsufficiency. So SHOX gene function in dosage dependent manner, the loss of function mutation of one SHOX allele results in disorder of SHOX deficiency which causes growth failure as seen in Turners. Turners is almost always associated with loss of one SHOX gene because of the numerically or because of the structural aberration. And growth hormone deficiency generally not a feature associated with Turners. They are short because of the SHOX haploinsufficiency. So invariably they have a normal growth hormone levels. So then the question comes, why should we treat with a growth hormone? So SHOX is essential for the regulation of chondrocyte proliferation and differentiation, and it encodes a cell type specific nuclear transcriptional activator primarily expressed in the osteogenic cells. SHOX acts as a repressor of growth plate fusion since it is specifically expressed the growth plate in the hypertrophic chondrocytes undergoing the apoptosis. So the haploinsufficiency of SHOX gene may lead to premature growth plate fusion in the distal limbs, so causing short stature. So there can be, as we have said, growth hormone will be normal, but there can be alterations in the IGF-BP axis in Turner syndrome. So despite the fact that growth hormone deficiency is not usually present in Turner syndrome, the growth hormone IGF-BP axis is disturbed. Increased IGF-BP3 proteolytic activity has been found in adult Turner syndrome combined with the low levels of circulating free IGF-1 and increased levels of free IGF-2. So probably that may be contributing. So now, having known about there is a short stature or growth failure as a universal phenomenon, how short they will be. So looking at the average length of the full-term babies of Turner syndrome is approximately 0.7 standard deviation below the mean for the general population. So it can manifest very early. So average untreated height falls below -2 standard deviation score by 4 years of age and below -3rd standard deviations in adulthood. So, and we have a separate charts that has to be remembered. So growth charts for the Turners are little different from the normal population. So Lyon et al. Constructed a standardized growth curve utilizing cross-sectional heights from untreated European girls with Turner syndrome in the absence of hormonal therapy. So that means looking at the natural course of a Turner syndrome, the curve is widely used in clinical practice and so the mean final height was 143 plus or minus 7 centimeters in the Lyon data untreated. So this is you can see on the left side, and this is the growth charts in comparison with the normal. This is the normal. These are all the charts for the Turner syndrome. Now coming to the growth hormone therapy. So various studies way back somewhere around 1992, 94 and all. So growth hormones therapy in Turners has shown little benefit. So improving various, in the sense height improvements was almost 5 to 20 centimeters have been observed. So comparisons of the studies, final adult heights of women with Turner syndrome who were treated with growth hormone show height gains after treatment in the form of significant increases of 5 centimeters or over. So than the predicted adult height. So a mean height gain over predicted adult height of up to 16 centimeters using a higher dose of human growth hormone, that is up to the tune of 0.63 milligram per kg per week, has also been demonstrated. So they require little higher dose. So treatment with recombinant human growth hormone is the standard of the care for a girl with Turner syndrome. It has been approved by the US FDA in 1996 as a non-growth hormone deficiency condition. And many studies have evaluated the growth hormone therapy in girls with Turner syndrome and revealed that growth hormone can increase adult height by to the tune of 5 to 12 centimeters in various studies. So the stimulatory effect of growth hormone on growth plate, chondrocyte proliferation and hypertrophy, which is partly mediated by increased IGF-1, can in many cases non-specifically accelerate the linear growth and thereby partially compensate for unrelated molecular defects affecting the growth plate. And actually initially they have used for the psychosocial issues, and there was a poor competence among the children with Turner syndrome because of the short stature. So initially they tried actually to improve the psychosocial performance, but subsequently they found that there is a true benefit with the growth hormone therapy in comparison with the untreated Turner syndrome. So that's how looking at the data, US FDA has approved growth hormone therapy for the treatment of short stature in Turner syndrome in 1996. So definitely it improves the quality of life in children with Turner's. And the next question is, generally we see very late presentation of Turner syndrome, somewhere around 13 or 13 plus, mostly because when the child is not growing and not attaining puberty, entering into the puberty, that is the concern for the mother. So then they will bring to us. So by that time, so it will be too late for us to, so the real challenge is making a early diagnosis of Turner syndrome. So it can be actually diagnosed prenatally, immediate postnatally, and during the childhood also, looking at the growth pattern and the appropriate other clinical stigmata associated with the Turners. So high index of suspicion is required, so that early and diagnosis can be made and early child can be instituted on the growth hormone therapy. So early is the better. So this is one study. So toddler Turner study, actually I don't know whether the last benches are able to see. Looking, so this is actually they have looked involved 9 months to 4 years of age Turner's children. So they have treated for 2 years. This was a randomized trial, and definitely they were look, you can see the corresponding graph. So the treated versus untreated, definitely almost 7 centimeters taller than the untreated children. So this is age between 9 months to 4 years, and subsequently they have, in the sense at the end of the randomized trial, so they were in the inter-study period, but again they had a thought, should we follow up these children who were treated with growth hormone therapy? So so they invited for the observational study, so which extended for up to almost, so for 10 years. So look at that. So there was, here the growth hormone treated during the study period did not receive the growth hormone here, whereas untreated actually they were provided with the growth hormone. So there was a catch down growth for the earlier treated, and there was a catch up. So subsequently the adult height was not different because of the catch down growth. Definitely the earlier treated children had a taller, throughout the study they remained taller than the untreated children. So that is the importance of early treatment. So these are the 2016 clinical practice guidelines with respect to management of Turner syndrome. So what do they say? Age of initiation, so early is the better. So how early? Around 4 to 6 years. So initiate growth hormone early, so at around 4 to 6 years of age, and preferably before 12 to 13 years, so that we can have a good impact with respect to the growth promotion. So child already has evidence of growth failure, that is in these circumstances actually. So 50 follow, that's why we should have a growth charts. So follow up the height, velocity and all, and all the causes have been ruled out. I think some problem with the. So various lines of evidence indicate that younger age at treatment initiation, including at least 4 years of treatment prior to the puberty. That means somewhere around 11 to 12 years in the puberty induction. So somewhere around 6 to 7 years would be the best thing. At that time, if you make a diagnosis, then start the treatment, that will be really improve the height. So I think same thing. So therapy may be continued until the girl, how long should we continue once we started on the growth hormone? So should be continued till the girl less than like 2 centimeters per year growth is been observed, or bone age is more than 14 years. And there is no transition as we see for a growth hormone deficiency children. So this is the recommended dose of growth hormone. Generally the dose is little higher than the dose what we use for the growth hormone deficiency children. So to the tune of various countries use different doses, but majority of the times 45 to 50 micrograms per kg per day, or 1.3 to 1.5 milligram per meter square per day. So in most instances, and increasing little higher doses depending on the response to the treatment and monitoring the IGF-1 status. So increasing to 68 micrograms per kg per day if adult height potential is substantially compromised. You can increase the dose. And this is the monitoring. So monitoring, like clinical monitoring with the height velocity and the height monitoring every 6 months, and the biochemical monitoring with the IGF-1. So IGF-1 at least annually, and maintain the IGF-1 less than minus 2 standard deviations, less than, if it is more than 2 standard deviation, so then we have to adjust the dosages, keep it less than 2 standard deviations for the mean for that a particular age. So this is how we have to adjust the dosages. And what are the factors? Do all of them, as we have said, even in the studies also they have observed varying from 5 centimeters to 20 centimeters improvement in the growth with the initiation of growth hormone. So why this so much of variability? So several factors influence the efficacy of the growth hormone treatment. One is the a relatively tall height at the initiation of therapy because of the parental tall stature. So tall parental, so familial or genetically they are at higher. So and mid-parental heights and young age at the initiation. Younger the age, so better will be the response. And longer period of treatment before induction of the puberty. Longer duration of therapy and little higher doses of growth hormone therapy. So these are all the factors which influence the growth promotion with the growth hormone therapy. So now oxandrolone. What is oxandrolone? Oxandrolone is an anabolic steroid, synthetic derivative of testosterone, which is non-aromatizable. That means it will not be converted to estrogen, and which is a weak androgen. So how does it help? So it can be used as an adjuvant along with the growth hormone to improve the height. So how does it help in growth promotion? So exact mechanism is not known, but works in synergy with the growth hormone. It augments the effect of growth hormone at the growth plate. So because it will not promote the bone maturation. So early fusion will not be there. At the same time, giving a milieu like steroid rich environment for the growth hormone to work effectively. So dose in the range of 0.03 to 0.05 milligram per kg per day. And the side effects, because it has a weak androgenic activity, so hirsutism, clitoromegaly and mild deepening of voice can be there, and it should be started somewhere around 10 years of age. So we have tried, but I think non-availability is an issue with our people. So this is a Cochrane database which has looked into the beneficial effect of oxandrolone as an adjuvant therapy to growth hormone. So in this database, they have like duration of the therapy was 3 to 7.6 years, and mean age was 9 to 12 years, and the benefit was mean difference in the height with respect to growth hormone alone versus growth hormone with oxandrolone was 2.7 centimeters. So favoring in like little benefit, modest benefit with respect to the height improvement with the addition of oxandrolone. So this is again another important thing is the puberty induction. So generally, traditionally what we do in our management of Turner syndrome who have been initiated our growth hormone, we delay the induction of the puberty with the estrogen. That is because assuming that addition of estrogen will cause a epiphyseal fusion, so that will hamper the beneficial effect of growth hormone therapy on the growth promotion. So that's why little delay will be there. So this is looking at, so this was the question in their mind. So with the low dose additional as an adjuvant to the growth hormone, does it have any impact with respect to the final height? So this is a double-blind placebo controlled So number of patients, 149 patients, age in between 5 years to 12.5 years, randomly assigned to 4 groups, like double placebo, that is placebo for growth hormone, placebo for estrogen, and estrogen alone, growth hormone alone, and the growth hormone for estrogen. These are the 4 arms. So dose of the growth hormone was 0.1 milligram per kg 3 times per week. That is a 0.3 milligram per week dose. And ethinyl estradiol was depending on the chronologic age and adjusted to the pubertal status. So this is the dose they have received. In between to 5 to 8 years, 25 nanogram per kg per day, and in between 8 to 12, 50 nanogram per kg per day. And after 12th birthday, so escalating doses because of the induction of the puberty. So thus, and growth hormone therapy was started when the growth velocity was less than 1.5 centimeters per year. So this is the, look at this. So there is a growth hormone alone improvement in the height standard deviation scores, and with the estrogen definitely almost 2 centimeters benefit with the associated use of estrogen. So this is the curves, growth hormone plus estrogen, that is the yellow line, growth hormone alone, that is the violet, and estrogen alone is the blue, and the double placebo is the orange colored. So in conclusion, so growth hormone treatment initiated at an average age of 9 years increases the adult height in Turners, and ultra low dose estrogen with growth hormone showed modest growth benefit. So hence practice of delaying estrogen therapy should be reconsidered. So the idea is, though they have started very early, prepubertal estrogen is not recommended. At appropriate age, somewhere around 11 or 12 years, you can start with the estrogen therapy. So which may have a, in the sense which may improve the psychosocial behavior as well as the neurocognitive function. So that is the message from this study. So puberty induction should be done like as an appropriate 11 to 12 years, and do not recommend routine small dose of prepubertal estrogen therapy, and 11 to 12 years. And once the appropriate pubertal development has occurred, then you can add with the progesterone, so that continued on estrogen and progesterone supplementation. So I think coming back to our patient, so this is how did we manage our patient? So growth hormone was started 3 units per day. So it is a lesser dose. Generally for our patient, as per the recommendation, requires 4.5 to 5 units per day. But because of the financial constraints, we started with a low dose. So and subsequently increased. And thyroid status was monitored because as per se, like Turner syndrome are at risk of developing the autoimmune thyroid disease, and during the growth hormone therapy also they can develop a thyroid dysfunction or hypofunction. So then it has to be monitored because it is again another important factor which can have a negative impact with respect to the growth promotion. So it was monitored, and estrogen supplementation was started at 15 years of age. So total height gain what we have observed in our patient was 22 centimeters. I think couple of slides I am going to complete. So this is the growth hormone chart for our patients. You can look at this like at the start, like here actually in between for again financial constraints, patients stop the therapy, and here at 15 years of, you can see the like how the growth benefit with the growth hormone, and you can see the no growth catch up. So when the patient stopped for a period of 6 months, and then we have added estradiol at 15 years of age and completed somewhere around when the growth hormone, like growth velocity is less than 2 centimeters per year. So somewhere around 152 final height she reached, and mother is happy. So take home points. So growth failure is the most common presentation of Turner syndrome, which is due to shocks haploinsufficiency, which is progressive from the infancy to adulthood. And growth hormone therapy remains the mainstay of treatment for treating the short stature Turner syndrome. So, and growth hormone therapy can be safely initiated at a younger age in individuals with Turner. The real challenge is to making a diagnosis very early. And early growth hormone treatment with induction of puberty around 12 years would improve the growth and the psychosocial behavior. Thank you for your patient listening.
Thank you, Dr. Neelaveni. Thank you.
Thank you, sir.
Any questions?
I am Dr. Jayasundar. For the male version of this Turner syndrome, can you give this treatment?
Newnans, sir, Newnans? Newnans you mean to say?
Males, in males. Turner
Noonan.
syndrome. Yeah.
Yeah, Newnans. It is also approved indication, sir. There are several approved indications like where the growth hormone deficiency will not be there, but growth hormone treatment can be used to improve the height. So one is the Turner syndrome, the Noonan syndrome, Prader-Willi syndrome. So there are, even in achondroplasia also it has been tried. Even the chronic kidney disease associated short stature also can be treated with growth hormone therapy.
Thank you, Dr. Neelaveni,
Thank
for
you,
the nice lecture.